Let's start with an uncomfortable truth about mid-sized medical practices. When complex data entry gets funneled onto the desks of highly trained clinical staff, the entire operation slows down. The American Medical Association looked at this recently. They found that physicians are working an average of almost 58 hours a week, but only 27 of those hours actually go to direct patient care. That leaves a massive gap. Every single week, a doctor loses 13 hours to indirect care tasks. That time is heavily eaten up by order entry and managing test results. When you force providers to spend a quarter of their week acting as data clerks, the toll is heavy. Over 43% of physicians report symptoms of burnout, and the burden of the EHR is a primary driver. This creates what practice managers call the bandwidth spiral. The second patient volume increases, urgent orders immediately back up, simply because the clinical staff managing them are already behind on their regular workflows. Relying on nurses and doctors to process a high volume of administrative tasks creates a bottleneck. It drags down the number of patients a practice can see and actively degrades the well-being of the providers trying to see them. If the clinical team is overwhelmed, the logical next step is to look at the front office. But medical office staff are already spending nearly a full 34-hour workweek solely on administrative tasks. The pressure of that workload has a direct result. Front office support staff turnover at a 40% annual rate. This chart compares a standard front desk salary to the hidden costs of replacing that employee. Every time someone walks out the door, you pay up to $12,000 in recruiting, onboarding, and lost productivity to fill the seat. And that lost productivity is severe. Order entry is not a skill you pick up on day one. It requires a deep understanding of specialty-specific protocols and weeks to properly ramp up in the EHR. Practice managers end up trapped in training fatigue. They spend their limited time constantly onboarding new local hires just to keep the order entry queue from stalling completely. Trying to solve an EHR bottleneck by cycling local hires through a role that has a 40. Right now, 15 to 20% of medical claims are denied on their very first submission. A leading cause of those denials is incorrect or missing order data. A simple typo in the EHR means the payer rejects the claim and revenue stops. Now your staff has to enter a costly rework cycle. Someone has to manually research the denial, correct the file in the EHR, and resubmit the claim, which can drag out your cash flow for weeks. A frantic, high-turnover order entry process actively damages your business. It delays patient care, creates preventable administrative rework, and strangles the practice's cash flow. To break this cycle, a growing number of practices are removing the order entry function entirely from their physical clinic. An in-house administrative hire costs $60,800 annually, combining a $35,000 base salary with benefits, space, and turnover costs. Compare that to Staffingly's dedicated remote model at $21,600 per year. This covers 45 hours weekly, training, benefits, and backup coverage with zero setup fees. Migrating to this remote model yields a 64% cost reduction. That is $39,200 in annual savings for every single administrative position you transition. Practice owners are essentially paying a $39,200 premium per seat just to keep their data entry staff physically in the building. For mid-sized practices watching their operating costs climb, that trade-off makes no mathematical sense. The operational mechanics are straightforward. A dedicated offshore team of healthcare-trained virtual assistants logs in and works full-time directly within your practice's existing EHR system. Security is handled at an enterprise level. The infrastructure strictly adheres to HIPAA compliance and carries SOC 2 Type 2, ISO 27001, and HITRS certifications. Once this remote workflow is standardized, you gain a massive technical advantage. The practice can layer AI document intelligence software directly over the human workforce to automatically read and categorize incoming paperwork. This flowchart shows how an automated safety net operates. The error prevention AI learns from past ordering mistakes and flags missing codes or formulary issues before the human assistant ever clicks submit. Quality control is enforced daily. Every remote team has a dedicated team leader for active supervision and a process manager who guarantees all service level agreements are met. True operational reliability at scale requires combining protocol-trained human specialists with automated AI safeguards. An overwhelmed local hire juggling the front desk simply cannot compete with that level of precision. Relying on just one local staff member leaves you incredibly vulnerable. One sick day can bring your entire order queue to a complete halt. The Staffingly model prevents this by inherently building redundancy into the team structure. Backup coverage is guaranteed, ensuring you experience zero queue downtime. This graphic tracks the deployment timeline. Most practices successfully connect to the remote team and go live within 48 to 72 hours. To mitigate initial risk, they offer a 2-week pilot phase to test the integration using your clinical protocols. Preparing for a dedicated remote team forces a practice to properly document its protocols. Even beyond the immediate cost savings, that process makes the business more resilient. If you run a micro practice with low daily patient volume, you might justify spending $60,800 to keep an all-in-one local hire on site. Total physical control has a specific value when the workload is small. But for growing mid-size practices dealing with clinical burnout and regular claim denials, continuing to scale your order entry by hiring locally is an unsustainable operational strategy. Remember the 13 hours a week your physicians are losing to indirect care. That is time that belongs to your patients. Reclaiming those clinical hours while simultaneously saving nearly $40,000 a year on every administrative seat is a necessary competitive advantage in today's healthcare market. Solving the medical order entry crisis is no longer a matter of buying another software tool. It requires systematically shifting the human workflow to a dedicated, scalable remote model.